So good morning, honorable participants and honorable speakers. My name is Jeremy from AMSA International, and I will be moderating the session for today AMSA International webinar series, Current Approach Towards COVID-19 for Day 1. I would like to say welcome and thank you very much for registering and broaden your knowledge via this webinar. I hope this webinar will give full of benefits towards us all. This webinar has a total of 445 registrants from 15 different countries: Indonesia, Singapore, Malaysia, India, Nepal, Bangladesh, Philippines, Thailand, Myanmar, Macau, Taiwan, Kyrgyzstan, Hong Kong, China, and South Korea. So today we will consist of 3 sessions, 2 of the lecture session by Dr. Gurbilas and Dr. Gurmit, and the final one is the question and answer session. If you have questions during the lecture session, feel free to ask the questions during the Zoom chat column. So please ask directly, and I will read aloud the questions in the question and answer session in chronological order within the 30 minutes time span. So you have to ask the questions during the lectures. It's okay. And kindly please fill the pretest before you participated into these webinars, because if you do not fill the pretest, you will not get the certificates. So we will begin without wasting another time. I will read aloud the CV of the first speaker, Dr. Gurbilas. So this is Dr. Gurbilas Singh. Dr. Gurbilas Singh is a practitioner at the Jivandip Center of Digestive Disease in Chandigarh in India, and he is a director of education and training in Sarfit Gastrocity in Amritsar, India. And currently he qualified as a MBBS in the Kasturba Medical College, Mangalore, India, and he also obtained the MRCP, the Member of Royal College of Physicians in the United Kingdom, and the Fellow of Royal College of Physicians in London, in the United Kingdom also in 2016. These are the CV of Dr. Gurbilas, and the next session I will give to Dr. Gurbilas. The stage is yours.
If you allow the share screen, please.
Yes.
Thank you very much. So thank you very much for having me here. And we're going to talk about current updates on COVID-19 diagnosis. I speak on behalf of Doctors Academy UK, GI Rendezvous, which is another organization which does awareness and education activities, and of course, Sarfit Gastrocity, where I do my regular job. I would like to start by thanking our experts, Ms. Harvinder Kaur from Malaysia, and Dr. Kanwardeep Singh, Professor of Microbiology and Principal Investigator, Viral Research at the Government Medical College, Amritsar. So a pandemic, as per WHO, is a worldwide spread of a new disease, whereas the US Center for Disease Control and Prevention defines it as an epidemic that has spread over several countries or continents, usually affecting enormous population. So widespread endemic disease with a stable number does not qualify as a pandemic. If you look at the history, there is a bit of in the olden days, we had smallpox and tuberculosis. Tuberculosis goes on now as well, but then smallpox has been eradicated. The recent ones are HIV and COVID-19, of course. And in the recent past, we have had H1N1, as well as the Spanish flu, which took a lot of lives. So we'll try to restrict our talk to how to diagnose in clinical practice and some manifestations and variations of COVID-19, the comorbidities and how can they, impact on the outcome, and a bit about surveillance. So going into the background, COVID-19 or SARS-CoV-2, it's a respiratory infection which can actually develop a severe pneumonia or can have a simple course of cough, fever, etc. Spreads by respiratory droplets like sneezing, coughing, and talking. And it also spreads from touching the surfaces and then touching your own mouth, nose, possibly eyes. And as we know now, many of the individuals can remain asymptomatic. To suspect and diagnose COVID in daily practice, we now know that most people will have fever. So fever, cough, and any shortness of breath or constitutional symptoms like muscle aches, or there are specific things like unexplained loss of taste or smell. Occasionally diarrhea and symptoms like headache can trouble people. There can be mild symptoms which may aggravate over the next week or so. And we know from data almost 20% can become seriously ill and need hospitalization. Most of them would be with some health conditions and usually over the age of 65. We'll just talk a little bit about a case. This also has the basis on the questions that we have been asked to give to the students. So Mr. B, a 35-year-old male, rings up for a teleconsult with symptoms of dyspepsia. His main symptoms were bloating in the tummy, a bit of heartburn, nausea, that is on taking paracetamol, he told me, and a sore throat with occasional cough. He did mention there was a bit of dysphagia, although this was only when he was taking any medication. There was a background of low-grade fever for almost 9 days in the history. But he quickly mentioned that he's already got it checked and he didn't think it was COVID as the test was negative. So here, one thing to highlight is never assume anything, and we have to take a proper history. And going in the history, we could easily see that the test was done probably on the 3rd day after he started with the symptoms sometime around Saturday night, and then Tuesday morning was when RT-PCR, which is a routine specific test for COVID-19, that was done. He said that he does get cough and, off and on during such seasons, but his oxygen levels were reasonable between 93 and 95. He was checking it at home. Most people are doing it here in India now. The family history included both parents being hypertensive and mom was also a diabetic. He was otherwise fit and well in the past with no medication, no allergies, remained a non-smoker all his life, and occasionally took alcohol. So just to explain the question, but I don't have to give the answers right now. So this is a question which will come to you. And also, this is the second question, the next step in management and where we go from what we heard in the history. And then if he's actually COVID positive, what we should be doing. I was told I don't need to explain anything right now because the questions will come to you. So we'll leave this at that. The clinical manifestation, the most common ones that we've discussed remain fever, dry cough, and some constitutional symptoms. But less common ones include diarrhea, redness or irritation in the eyes, some sore throat, and some loss of taste or smell has been certainly mentioned. If we look at the data, the most common symptom, almost 90% of the patients will have fever, and a lot of patients, almost 70%, will have dry cough. There is mention of almost 30%, 1/3 of the patients may have productive cough as well, and lots of constitutional symptoms, including myalgias and muscle pains, etc., with headaches. So the silent infection in SARS-CoV-2 makes it very difficult for surveillance and as well as for looking for real patients with this problem, and hence the spread has been phenomenal. The testing positive for SARS-CoV-2 without clinical symptoms and abnormal chest X-ray imaging has been one of the things that people have been trying to do. And there has been some acute respiratory tract infections which are very, very minor, like just some throat pain, nasal congestion, and fatigue. And the mild pneumonia, which can be with or without fever, with some respiratory symptoms and sometimes even without any shortness of breath, has been noticed. But sometimes, as we saw, 1 in 5 cases can have severe symptoms, And severe symptoms here would mean a pneumonia, which leads to accessory respiratory muscles being used, dyspnea, the oxygen saturation is falling below 92%, and the respiratory rate going up almost 30 per minute as per the guidelines, as per what we see. And there can be disturbance in consciousness. We've seen post-COVID convulsions in patients. The patients are unable to eat more because of reduced appetite, but sometimes it could be feeding difficulties as well. And on a high resolution CT, we see infiltrates. There are also some lesser known symptoms. Thromboembolic events have been much more common in data from France, Netherlands, and China. In India, we haven't seen much of this, but they are well documented now. There is also some data on skin manifestations still being looked for, and the WHO is doing, collecting this from various national registries to look for rashes that have been seen, which are specific to these COVID-19 patients. This is a slide from Malaysia, which is a very recent thing, in which they have specifically mentioned that little more than 50% of the patients remain asymptomatic. So 1/3 can be symptomatic even without a pneumonia, and 13% will be seen with pneumonia, but there will be no hypoxia. But critically ill is just under 5% now, as per the Malaysian data, and 1% would be really critically ill, requiring ventilation and all ICU care. So at this stage, when Malaysia is going through its third wave, they have said avoid 3C and practice 3W. So avoid 3C means crowded spaces, closed spaces, and closed conversations should be avoided. And the 3Ws are washing hands, wearing masks, and warnings like physical distances. Rather than social distancing, we have started saying physical distancing now. Looking at the comorbidities, the four major things we have are obesity, diabetes, elderly people, and hypertension. So a meta-analysis has shown these three to be most important: hypertension, obesity, and diabetes. But the data also mentions that over 65 older patients have got increasing risk, especially if they have comorbidities. And this could be because the elderly people, there is usually a change in lung anatomy and muscle atrophy, which leads to some physiological changes, leading to reduction in the lung volume. And also because of the age, sometimes we face low immunity status, and that can increase the chances. The data has also mentioned one more condition which is very prominent: chronic obstructive pulmonary disease, which is a respiratory illness and puts people with this condition to almost 4-fold higher risk of having COVID-19 as compared to normal individuals. Huang et al. And Wong et al. Have both reported all these things, that cardiovascular disease, diabetes, hypertension, and COPD are one of the major factors in which COVID-19 can be disastrous. And in the Wong et al. Series, they've said almost 37% needed ICU in normal population, whereas with comorbidities, almost 3/4 of the patients needed ICU care. The hazard ratio among patients with at least one comorbidity was lower as compared to two of the comorbidities if present. So definitely anybody who's a diabetic is usually a hypertensive. So that makes things difficult for elderly people, especially, who are more prone to such diseases. So this data, if we see, places hypertension as the most important factor, seconded only by cardiovascular disease and diabetes. So just highlights what we've been talking about. Now, when a virus infects, the immune response initially is an innate immune response, which means your interferons, the cytokines, the other chemicals, they start fighting with the infection. They interfere with the virus replication. And this can lead to our constitutional symptoms like fever, headache, stuff. And before we go to the adaptive immune response, step 2 of the immune response, sometimes in immunocompromised individuals or weak immune status patients, this step 1 innate immune response goes on for a longer period. If it goes on like that, it can damage more body organs, and hence it can cause severe pneumonias or severe symptoms to such patients. In the laboratory, we have got various analysis methods which have led to SARS-CoV-2 detection. These include blood, feces, anal swabs, and many other specimens that we will discuss here. In the blood work, like any other viral infection, we see leukopenia, mainly it's lymphopenia, and thrombocytopenia is also seen here. The other thing that was noticed in most patients was that CRP was elevated. These are all non-specific things. These can be in any viral infection, I suppose. The CRP has been highlighted here, although most patients with many other conditions will have a raised CRP too. The various places where we take the examination swab from, in this table, which looks slightly busy, but we can easily see the first one, nasopharyngeal swab. Now, this is the most important one and is being recommended because of the ease of taking it. Whereas oropharyngeal swab, bronchoalveolar lavage, tracheal aspirate, and things like those are used for more sick patients. As an outpatient test, as an, just going to a lab and having it done easily, nasopharyngeal swab has come out to be the most important one. So there are blood works and stools as well. But as we'll see, nasopharyngeal swab, why has become more important. This graph basically shows the immune response to viral infections. And the incubation period has been shown by various data now to be almost 5 days. So if we have done a test within less than 5 days of exposure, then possibly we'll miss the virus. So it is recommended, if something like this has been done, it's important to recheck it. Now, the symptoms usually last from day 5 to day 15. And then after that, various antibodies kick in. This graph again shows it more clearly. If we see the red part, that's where we can actually miss the virus. So a very small window period there. So day 5, even here we consider that's the best way we can catch the virus in our tests. Antibody tests have been used, but they're usually not recommended for checking the virus. Yes, the immune status later with IgM and IgG can be checked with this. However, a negative antibody test cannot exclude infection because it may be early during the disease onset. So we cannot take antibody tests as a proper tests here. This graph shows us about the antibodies, the purple one and the green one we can see as IgG and IgM. There is talk about IgG disappearing. So IgG gives a chronic state. The antibodies are present and the infection cannot happen again. Whereas IgM is the acute stage where the infection is going on. And there are patients we have seen whose total antibody status remains very high. And many of these are IgGs, which slowly come down again. But the data is still awaited as to what happens after that. So various tests being done. The nasopharyngeal antigen detection test is the main test, initial test, although it may have a slightly low sensitivity, but the specificity is pretty good. And what is normally recommended as a nasopharyngeal swab for antigen detection should be done as a first thing because the time taken for the results is pretty small, whereas RT-PCR takes a longer time. And hence, till we wait for that, for confirmation, we can simply do an antigen detection test through the nasopharyngeal swab. RT-LAMP or another RNA test can also be used, but it's probably as good as RT-PCR, but RT-PCR is more popular as such. Similarly, if we look at the advantages and disadvantages, the nasopharyngeal antigen detection test is the easiest to do, and even with very less equipped labs, we can easily do this. Whereas RT-PCR requires some equipment which is special, and this can be done as a confirmatory test later. And there are other tests, of course, enzyme-linked immunosorbent assay and the chemoluminescence immunoassay. These are standard tests used for various other viral detections. But the rapid detection test, we take it as a weekly screening in high-risk individuals for doctors, especially in India. It was being done for high-risk individuals who were looking after COVID patients. So this is a pretty good screening test, and data from cohorts have really appreciated this. So if we develop a small algorithm, which is basically used in India here, so rapid antigen test, if positive, irrespective of the symptom status, we reported that the patient has COVID-19. If it comes back negative and the patient is asymptomatic, then we can repeat test if the patient becomes symptomatic. Otherwise, we just leave it at that. Or otherwise, if the patient is symptomatic with fever or sore throat or cough, then definitely a confirmatory sample has to be sent for RT-PCR. There has been talk about doing CT scans as a surveillance as well as screening for patients. At least in India, there has been instances where private healthcare is accessible to patients. They simply, whenever they develop some shortness of breath or cough, they simply go and get a CT scan done for themselves. However, it should be done under a doctor's guidance, of course, and confirmatory test with PCR is important here, because a CT scan can show a pneumonia for any other cause as well. An X-ray chest may not be recommended as a first choice, because simply an X-ray chest shows only 40% of the lungs, as we know, and generally it's a vague test when it comes to specific conditions and may miss early consolidations. And HRCT would be the test to look for. In various studies and various data, abnormalities on X-ray and CTs have been compared, and we have seen a CT to be much better as a test for radiological findings for any reason, but specifically for COVID-19, a normal chest X-ray will still have clear abnormalities on a CT. There are certain other biomarkers which are being evaluated. For example, saliva, which seems to be a reliable tool, but and it could represent a valid instrument for diagnosis, but it's not being used routinely as of now. Similarly, stool. In one study, it has been shown 57% of the infected patients, they remained positive for COVID-19 in stool beyond nasopharyngeal swab, so by median of 4 to 11 days after that. And the persistence of PCR in sputum and stool was found to be similar in some studies. Also, there has been talk, we know very well from before, that respiratory infections can, affect our ocular fluid. It can, the viruses, they can come to ocular fluid. So for this reason, it has been hypothesized that we can check the nasolacrimal system also, and tears can be used to check for COVID-19. Certainly, there are other proteins like nucleic acid tests and viral proteins, antigens, antibodies, as we discussed, IgM, IgG, which can be checked. And there are, protein cell and cellular markers like CRP. CRP is, as a serial CRP, we use it for, many other conditions like starting from cellulitis, inflammatory bowel diseases. So various conditions it has been used in the past, and in COVID-19 it has been shown by various studies that a trend is very good in predicting how things will be. So an elevated CRP and even D-dimers have been shown to be associated with COVID-19 infections. And a one-off CRP may not be of helpful in any patient. So there has to be a trend that has to be noticed. So whether the CRP is coming down in due course, that would signify probably a better prognosis. Similarly, thrombocytopenia and lymphopenia, as we discussed earlier, which are vague, tests for any virus, any viral infection. So the white cell count itself can go up along with the deranged LFTs and creatine kinase. Serum ferritin, it has been noted, it's just an acute phase reactant. So just like CRP, even ferritin can go up. But I personally wouldn't recommend checking ferritins or serial ferritins for this. When we have CRP, that should be good enough. And the challenge using these biomarkers is always the cellular markers is that nothing is specific. They are all slightly vague and non-specific. So just summarizing what we have just discussed, NHR-CT is considered to be a very good test, which would give us a good idea about the interstitium of the lung. Similarly, the RT-PCR analysis of nasopharyngeal swab, tissue sample in patients who have passed away, who are no longer there, they can still be obtained from the tissue, so we can use that for RT-PCR. And stool, again, for RT-PCR can be used. There are other tests for ELISA, and for rapid detection, we've got card tests, which are very helpful in at least initial assessment. And all these tests have been validated to do. Coming to the surveillance, now surveillance is basically to look for trends within a population, having a national registry or an international registry and looking at how we are doing, whether we are getting new cases in a particular region. So to detect new cases, it's very important so that we can risk stratify a region or a population. So for risk assessments, we need surveillance, and how we can, monitor our preparedness or guide our preparedness and response to such trends, to new cases. This is where our objectives are met through surveillance. So when we talk about surveillance, first thing we have to understand is who is a suspect. So as we all know, probably whoever has gone to a hospital, whether it's a patient or a healthcare worker, we always check the temperature these days. So it's one of the screening tests now for COVID when one has to enter a hospital. At least in India, that's a norm here. So anybody with the acute respiratory illness and fever or cough or shortness of breath, any one of the two, together with all these things, we can simply say the risk is much higher to have COVID. There's also an added factor, history of travel, because if there is a location where there is lots of cases reported and the patient has been coming from that area or had history of travel there during the last 14 days, 2 weeks, so he becomes a high risk individual, so hence becomes a suspect. Also, anybody with acute respiratory illness and confirmed contact with any COVID-19 case in the last 2 weeks becomes a suspect. Anybody with severe acute respiratory illness where we cannot explain the symptoms with anything else. So anybody with cough, shortness of breath, and fever, we can easily put it as any flu-like symptoms. But in the era of the pandemic, it becomes very important to first, check COVID-19 rather than putting it directly on any normal flu. So contact can be anybody when you have been in contact with a positive case or a high-risk individual for more than 15 minutes in a room or at close quarters within 1 meter of distance. Hence, the consultations or hence the contact with the patients, whether it's in operation theater or wherever, if it is going to be more than 50 minutes, it's high risk, and we should avoid it unless we know the status of the patient. Similarly, a direct physical contact, touching a patient or touching an individual who is a confirmed case, we become a contact with them. And if we are in the care of a patient, whether at home or in the hospital where we are looking after the patient as an attendant, we become, a direct contact. And there are other low-risk assessments, local risk assessments in various countries where they mention that these are the reasons where patients can be considered contacts. For practical purposes, so the period of contact is measured almost 2 days prior to the 14-day period. So that's what we consider a contact would be. For healthcare workers in surveillance, there are certain strategies that can be used for passive or active case finding strategies. It's easier to educate healthcare workers, anybody who's working in the hospital, and suspected cases can be easily identified if they're trained. And this could be something like, in inpatients, clinical care providers can simply evaluate their patients for signs and symptoms. A patient who's admitted not for any symptoms of COVID and develops new symptoms can be easily identified by anybody who's working in the hospital. Similarly, healthcare workers can monitor themselves, and in case they have any new symptom which can be related to COVID, they can easily tell their employers and can self-exclude themselves from work. So training and education for doctors, it may be easy, but for other workers, there has to be some sessions to train them for this. And similarly, monitor and manage ill and exposed health workers. The sick leave policies have to be monitored accordingly. And established reporting within the different healthcare facilities. This is very difficult in a country like India, but this for COVID-19 and for such diseases, certainly we all have to report the cases and we have to communicate to the public health authorities. Similarly, enhanced case finding strategies are used for COVID-19 patients. They are in place internationally. The routine surveillance, which requires that normal population, the routine populations, any symptomatic cases, including healthcare workers and frontline workers, are identified. But all asymptomatic, as we discussed about contacts, so all these people who have been contacts of high-risk patients in families, in workplace, anybody who's over 65 years of age, immunocompromised with various comorbidities, and all these patients who have been in contact with a laboratory confirmed case within the 5 and 10 day period of coming in contact should be tested. Also asymptomatic high-risk individuals. So if we can do that in a containment zone, that's what is recommended. And ideally, they say 100% people living in a containment zone should be tested by the rapid test. In a non-containment zone, for example, history of international travel in the last 14 days, all symptomatic individuals should be checked, of course, and the contact of a laboratory confirmed case, anybody who's been confirmed, and somebody living with the patient or in contact with the patient must be checked. All symptomatic healthcare workers, frontline workers, and who are in a containment zone, doing various activities, supportive activities, have to be checked. Anybody who's got influenza-like illness has to be checked. We cannot assume that this is a simple cold. And all asymptomatic high-risk contacts in the family, workplace, everywhere, and especially who's over 65 years of age, has to be checked. Within the hospital settings, there are certain things that are being done. Most patients who have been in the hospital for more than 3 days, more than 5 days become, and are elderly, they become high risk for any infections. So within the hospital, to stop the spread of COVID-19, we have to be more vigilant. And, anybody developing influenza-like illness symptoms or severe acute respiratory infection have to be looked after in a different way. Similarly, patients who are going for elective surgeries, endoscopies, ERCPs, any other procedures which require hospitalization or coming to hospital, and doctors or nurses spending time with them, they require a COVID test prior to this, as do all pregnant women who are hospitalized for delivery. Just a few references here of what we have talked about. Before I end, I would like to just mention it here, as we are talking mostly to the students. So a clinician should never make assumptions. History is the most important, part of our management of the patient, and this should not be missed. Since medical technology keeps changing, we have to keep abreast, and that is why it's very important that we either as peers talk about it or listen to the experts regularly. Just like clinical guidelines, even laboratory testing algorithms keep changing. We know so little about a thing like COVID-19. We would have seen many U-turns in the last 6 months, the way the patients were being managed, the way the new medicines or the old ones, which were guaranteed to be used, have been changed and then come back and then changed again. Understanding the rationale of treatments, of testing are very important. So as young doctors, it's very important to understand as well as apply it to daily routine. And we should always think about safe practices for our patients and for ourselves, of course. And preventive measures. When we sit in a clinic and we look at a patient, it is not just the condition they have come to us for treatment. It is also for preventive things, preventive healthcare, which is most important and is our responsibility as well. I would like to end by just simply showing you this slide of a collage of our activities at GI Rendezvous, where awareness and education activities are regularly being done all over the state of Punjab and Chandigarh. And we regularly, proactively get people to join us, normal population to join us in awareness activities in all sorts of medical conditions which are preventable. Thank you very much.
Thank you very much, Dr. Gurbilas, for sharing the very useful information about the approach of COVID diagnosis.